off we go. So now I hope to tell you why those answers are true. As I said, I'm a physiologist. I work in Amsterdam. I'm head of the Department of Translational Physiology, and I work 2 days as a physiologist in Rotterdam. So it's very nice to follow a cardiologist with a talk on the microcirculation, because their business really should be the microcirculation, because that's where all the action happens. Now, normally speaking, that would not be a problem if all the problems that we had in the cells were caused by a reduction of cardiac output, but they are not. As Dr. Weil told us, the problem in critical care medicine is not what comes out of the heart, but it's the distribution of that cardiac output where the problem is, where most of your patients are dealing with. It is distributive shock. So we are not interested in what comes out of the heart. We figure that that is pretty more or less fixed. If it's not fixed, you really have a problem. But it's the distribution of that normal cardiac output. It's a vascular pathology. So there is, as the previous speaker also said, an obsession with convection. And there is a lot more going on in oxygen transport than just pushing flow. And as we can see here, the big problem comes in the perception of the clinician that we have to, as Dr. Mythen says, make more trains go to the tissue. So that's why there's always a problem. And the idea is that water or watery fluids is the vehicle with which that is happened. So too much or too little, that is always the question in fluid therapy. And both have got a good and a bad side. And as you can see, the bad side for fluids is a lot larger list than the good side. And what people forget is that we need the red stuff in the blood to transport oxygen. It is not without a reason that we've got hemoglobin. And the reason for that is that we all know the dissociation curve, but what people forget is that only about 3% of total oxygen transport is done in plasma. You do not transport oxygen with fluids. None at all. That's a lecture in itself. Blood is good, certainly the blood that we have in Northern Europe these days. But that's another story. And fluids are drugs. They're like steroids. They're like insulin. They do some good, but they do so much bad. All the physiological signals that we need to cause autoregulation disappear. PO2 goes down, hemoglobin goes down. Paul Elbers will tell us that SID changes, osmotic balance, volume, and then I'm not even talking about the metabolic and inflammatory. You get this all together as one big soup when you decide to give fluids to your poor patients. And let's not forget that one bag of this is equal to 50 bags of chips. Now, would you give your children that to eat? 9 grams of sodium chloride is a lot of salt. And we are finally convinced, because we always need the clinical study before clinicians finally listen to what physiologists are saying. And now we have some evidence showing that really patients are having a big problem with the massive amounts of sodium chloride being given to patients. But there are also some problems that we have with the physiology too. We've seen this type of Frank Starling curves. Let's not forget that 80,000 liters a day of fluids pass your microcirculation. Only 20 liters due to convection and a massive amount to diffusion. Yet when we talk about diffusion, there's really no one that takes that into consideration, what that really means in clinical practice. And that's why the microcirculation is really the place to be when we're talking about these issues. So, if microcirculation is the place to be, we have to monitor the microcirculation, and we have to see what's going on in there. And not just looking at a number, but we have to understand its physiology. And that really wasn't around in clinical medicine at all until our introduction of these handheld microscopes. The first generation was the OPS imaging. Later we improved it with the SDF imaging, and as a lot of you know who's been to the critical care meetings, this has really opened up a lot of different insights into the importance of the microcirculation in understanding functional hemodynamics at the cellular level. And this one is the latest device that's been introduced just recently, actually this month, only very, very light, giving a very crisp image, large megapixel sensor, being automatic focus, etc. And we think that this will be a device which will allow us to really start using this in the clinic. And these are the images that you see underneath the tongue when you measure it. You can see here some leukocytes going down here. And there are two important phenotypes of the microcirculation that you immediately see. There's the convection. We know flow is important. You have to have movement of blood in order to transport oxygen. But equally important is the density of the perfused vessels, because that will determine what the diffusion distance is of the oxygen from the vessel to the cells. And diffusion distance is as important as convection when it comes to transporting oxygen, and something we forget completely. I will come back to that important area. And since then, a lot of different studies with our introduction of these devices have looked at the microcirculation as a therapeutic target, especially in sepsis, where distributive shock is most rampant and is the most difficult to correct. But we've also gone to more exotic places. In fact, I was yesterday in the North Pole, and I have looked at reindeers, and especially reindeer noses. As you can see here, we've put them on treadmills, and reindeer noses have got very interesting circulation when it comes to controlling their brain temperature. And I'm pleased to say that you can read all about it in the British Medical Journal. I just thought I'd plug this in the Christmas issue coming up on why Rudolph's nose is red. But getting back to more serious aspects of oxygen transport, again, basic physiology that everyone needs to know. Oxygen transport to tissue relies on the number of red blood cells being transported, convection, and the distance of that filled capillary to the mitochondria, the diffusion. So when we have heart failure, we will have normal diffusion distances, but we have a problem in convection. We have to support the pump. But in hemodilution, as we will see, we've got a normal convection, even a high convection, but we lose blood vessels and we lose out on diffusion, which is why when you give fluids, it's possible to have a very high flow, but with raised lactates. It's diffusion which is the problem. So, as physiologists, we can use clinical scenarios as models, really, for physiological concepts. And if we want a real beautiful example of hypovolemia, it is, of course, the hemodialysis patient. And in this study, we looked at underneath the tongue at the microcirculation. Before dialysis, this is flow in the microcirculation, and normal is 3, and you can see that patients who've got renal dysfunction have got a low flow normally. When you do a Trendelenburg and do a leg raising, you see an improved flow. If you then put them on hemodialysis, you get an enormous reduction in convection due to the extraction of the fluids, of course. If you then give a leg raising, you see an enormous response, which, of course, is a classic example of fluid responsiveness in these hypovolemic patients. What's the other side of the story? It is when you start giving fluids. Because what happens with fluids is, as you can see here, whereas we had a convection limitation in the hemodialysis patients, now we have a diffusion limitations when you start giving fluids to your patients. And here we see in cardiopulmonary bypass, for example, you see that the large vessels in one and the same place, before and after fluids, you see that the large vessels remain filled, but you see the disappearance of the smallest capillaries. So even if you have normal flow, you've got a larger diffusion distances, a smaller exchange area of your oxygen, which explains a situation why you can have a raised venous saturation in the presence of high lactates. It's due to diffusion. And this is what can happen to your patients when you're giving fluids. So it's not surprising you can have cerebral dysfunction following such operations. So how do you correct diffusion distances? The only real therapy that you have is to give viscous fluids. And the best viscous fluids to give are blood transfusions. And that's what you see here, chorauritic. Here you see the response of the microcirculation to hypoxia. It's not an increase of flow, it's the recruitment of the microvessels and a reduction of the capillary distances, which is the physiological response to hypoxia. The exact opposite of what you do when you give fluids, where you reduce the viscosity. So if you give a blood transfusion, you do very little actually on the flow, or the velocity rather, but you can see that previously empty blood vessels increase, and that explains the increase in hemoglobin availability. So what do blood transfusions do? They reduce your diffusion distances, and that's the mechanism by which improved oxygen transport to tissue is done. So, Manu asked me to talk about capillary leak. Well, there's a lot happening on the capillary leak syndrome. Very few papers really describing capillary leak syndrome. This is the last one in critical care medicine, and we are dealing with, unfortunately, outdated physiological concepts. Starling law is something of the past. This type of anatomy of the endothelial is something of the past. We've got new insights, and the glycocalyx has been a very important. Our understanding of capillary leak syndrome remains fragmented. A lot has happened on our understanding of the leak. And it really has to do with the important work done by a number of co-workers looking at the glycocalyx, which is a gel-like layer in between the red blood cells and the endothelial cells. And we didn't really know that this was present. It was known that these molecules were there, but what was not realized was the incredible thickness that this glycocalyx layer has. It's a gel-like substance. This is an electron microscope artifact. A whole bunch of antioxidant molecules are in this layer. There are transmembrane structures. It's a very important transduction mechanism for translating hemodynamic variables into nitric oxide and to regulate vascular tone. It plays a very important role in hemostasis, and its degradation is key in understanding arteriosclerosis, diabetes, and really all types of vascular dysfunction. And it is actually the disruption of the glycocalyx barrier which is the cause of tissue edema. And you can immediately see here, this is a very nice a review article on hepatic, that these chaps here are your adhesion molecules, which normally do not come in contact really with the leukocytes or with the red blood cells. But when the glycocalyx is depleted, like occurs in oxidative stress, which is the main pathogenic component which gets rid of the glycocalyx layer, that's when the vascular barrier becomes compromised and you get vascular leakage. And here you see the adhesion molecules now coming into presence and causing leukocyte rolling and extravagation. What about edema? Well, this is one of the early studies which really showed Hans Fink is a very important mover in this particular area. They looked at myocardial edema with the glycocalyx and without the glycocalyx and looked at the distances between the capillaries and showed a very clear association between depletion of glycocalyx, a disruption of the vascular barrier, and increase of the capillary distances, i.e. more tissue edema. We had done an early study looking at the effects of hyperglycemia, immediate hyperglycemia, and showed hyperglycemia, of course, is associated with oxidative stress. And we also showed here using tracers and also looking directly at the microcirculation that acute hyperglycemia as opposed to chronic hyperglycemia is a direct method of really getting rid of all of the glycocalyx in this particular rat study that we did. The different types of fluids also have a different effects on the glycocalyx layer. And starches, has been shown by these number of studies done by Matthias Jakob in München. This has been talked about before. They looked at really the seeping of solutions out of a heart here. And here you can see here that a lot more NaCl really goes through the vascular barrier than the starches, the hydroxyl ethyl starches, specifically the 130 kilodaltons, very, very well in maintaining that volume intravascularly. So here's Hans Fink. And actually analyzing the images of the microcirculation allows you to actually demonstrate the presence or absence of the glycocalyx. And it really has to do with the leukocytes which go through the capillaries and push, as it were, the gel aside and causes a accumulation of red blood cells behind the leukocyte. So if you look at the pulsations, as it were, of the capillaries, you can say something about the presence or absence of the glycocalyx. And Hans Fink, what he has done was he has made a software package in which it's possible actually by analysis of these images at the bedside to tell you something about the presence or absence of glycocalyx. This is just online, and it's their first real paper showing the presence of problems with the glycocalyx in these patients on dialysis, looking at the differences in the actual column of red blood cells. Here you can see depletion without depletion. Also showing actually biomarkers, which are the products which are shedding from the glycocalyx, also present, and the relationship between the two in normal as opposed to patients on dialysis. Now, what about fluids? All fluids are bad. All this story about colloids are better than crystalloids, it's all, in my opinion, science fiction. All fluids are bad because they cause inflammation and they cause oxidative stress. In fact, we looked even at the study, ACIX, someone will probably undoubtedly talk about it, which the composition is about as close as you can get to human serum. Looking at a balanced salt solution, a colloid balanced, unbalanced, it doesn't really make any difference. The problem is, the more you give, the worse it gets. So crystalloids, because there are hemodynamic targets which allow you, give you a green light to give more and more, that's why they become worse and worse. And that's why it is really not very logical to look at crystalloids with the same dosage as done in these big randomized, so-called randomized trials, because the dose is not being controlled. And it all has to do about the amount of fluids that you're giving. Because if we look at fluids, and like I said, it doesn't really matter what you give, all of these fluids cause, this is nitrosol, stress, myeloperoxidase, tumor necrosis factor, IL-6, all of them go up. And here we see the biomarkers really for hyaluronic acid. And here we can see also the NGAL and fatty acid binding protein all become bad, really, when you give fluids. Fluids are pro-oxidative stress, and in my opinion, each fluid should be accompanied by an anti-inflammatory. And I would advise you just to give vitamin C, co-administer it with your fluids if you want to control, especially renal damage. But that's another story. What about the lungs? Well, this is a whale lung, by the way, which is quite an impressive image, but I'm sure that your lungs can get like that if you have too much fluids inside them. And also, starches, again, are very protective in terms of lungs, in terms of extravagation, again, of water, and also of control of inflammation, as shown in this study, for example, by Cooper. What is very interesting study, which has just come out in Nature Medicine, which I really would invite you to have a look at if you're interested in this particular area. What these authors have really shown in a very, very elegant study is what they're suggesting is that sepsis, hi there, I'm almost finished, is that in sepsis this results in, you're coming rather quickly here, that in sepsis you get an activation of heparinase, and that this is what is causing the degradation of the glycocalyx, and that heparin actually is a very good compound in protecting the glycocalyx and causing a reduction in acute ARDS in this mouse study. I would just like to end up with some comments from a physiologist on these big trials that we've been seeing out there. Now, we had a closed round table on types of intravenous fluids in Jean-Louis Vincent's meeting. And the chest trial had not been come out yet, and we sat there. And there was a big discrepancy between two types of attitudes. Physiology is the only polar star we have, Luciano Gattinoni. And the Australians that said, we don't really care how fluids work, only large randomized controlled study with positive clinical outcome provide the only true relevance. And this is really a big problem. You cannot look at these type of compounds blinded. Because if you are blind, you don't see anything. And you certainly don't get any information about what these compounds are doing. And I would be very wary about looking at these type of trials and applying them to your patients. So, in conclusion, you'll be happy to know the only physiological compartment where all of this is really happening is the microcirculation. And this slide has been shown before, but it really is a great slide. This colorful gentleman is Paracelsus, the father of toxicology, who says all things are poison and nothing is without poison. Only the dose permits something not to be poisonous. And these are my conclusions. Sodium chloride, I think, should be banned. They would not pass a phase 1 trial if we would do it today. Too much or too little fluids are bad. Don't forget tissue oxygenation. We really do need oxygenation. A hematocrit below 30% is bad for your kidneys. Convection and diffusion are the key elements. Don't keep your patients anemic. We really do need blood for a reason. Red blood cells are good for you. Watch out for the glycocalyx. Reduce oxidative stress. And finally, be wary of blinded trials. And finally, you'll be pleased to know clinical tools are presently available to look at the microcirculation at the bedside. Thank you very much.